lot of chaos happening in the Middle East. This webinar is coincidental with what is happening there. Uh, it is like a silver lining amongst the black clouds. We've had the fortune of attending MENA Congress, Middle East Spine Congress recently in Dubai, and it was an eye-opener. The amount of spectacular work that we saw during the conference was extraordinary. So, wars or no wars, back pain will continue, neck pains will continue, spinal treatments will continue, advancements in spine will continue. And one of the crucibles, one of the laboratories of minimal access surgery is Middle East. The kind of amazing work some of these leaders are doing is in terms of execution, innovation is outstanding. So we wanted it to, be just not an eye opener for us, but to reveal their treasure of minimal access knowledge to the entire world. I think the best platform would be the SMISS AP webinar for such an exposure. So we have fantastic faculty today from Iraq, from Dubai, from Jordan, and we have one of our best moderators in the form of Dr. Raymond Yip from Hong Kong and Ayush Sharma from Bombay. So the stage is all theirs. So you'll get exposed to the entire spectrum of minimal access, from tubes to endoscopes, both uni and biportal, to deformity corrections using minimal access. So the platform is yours, Raymond and Ayush. Please take over. Thank you.
Okay, thank you, Arvind. Welcome, everyone. We are trying to cover the whole spectrum of MIS, starting from the endoscopy. So let me introduce my good friend, Dr. Ghawzan Hasan, and he is the head of spine department at Middle East Hospital in Baghdad. Not only that he does endoscopy, but he does the full spectrum. So he's one of the best guys to really cover it. He is good hands with endoscopy, tubes, UB, you name it, he does it. But we chose him today for endoscopy. So he will be talking on his experience in monoportal endoscopy. Over to you, Ghazwan.
Yeah, thank you for this nice introduction. I hope I deserve it, actually. And I would like to thank SMISS AP for this activities. As you mentioned, I think this is a very good activity in order to share our local experience in the Middle East to all of you. So this is my disclosure, and I think that's I will in the learning curve. I will cover some point that will be highlighted in this slide. Let's say for this moment, for me, let's say when you remove such a huge disc with the 8 mm incision, it's a game changer for me because it's a completely let's say endoscope. And with a very small incision, and the patient can walk in the same day and discharge it. This is the phenomenon. So when it's come to the endoscope, I think that it's still trendy, although the AI started to push away. But if we check the literature, that's the number of the publication in the up to 2020 become markedly increase, and also the scope of indication and the clinical application become wider and wider. And I think that's we are living in the golden age of the endoscope. And when it's come to the generation, I think that's the first generation was transforaminal in-out technique, and then the second generation is the interlaminar approach, Uniportal, and then after that, the third and fourth generation it's become when the scope of indication is started to expand, that including most of the spine pathologies, including revision cases, let's say stenosis cases, foraminal stenosis, and even the fusion when it's needed in this case. So the philosophy of the let's say of the endoscopic spine surgery is the extreme preservation, and this is the key point that the endoscopic spine surgeon want to deliver to the patients and among other colleagues. It's almost let's say you can do the job with a zero collateral damage, and the Monoportal endoscopic spine surgery represent this philosophy with extreme tissue preservation when it's come to the other technique, that's including the old open technique and even the tube and the other technique, which is the UBE. So when it's come to the evolution of the access, I think that we started with the open, then tubular MIS, then UBE. This is the evolution among the collateral damage that's occur, and the minimum let's say collateral damage to the surrounding soft tissue is the monoportal technique. So the coaxial advantage and the outcome, I think that's when in this slides, imagine that it's regarded as a day case, and the patient can start walking after 2 to 4 hours from the surgery, when he recovered from anesthesia, and can discharge home in the same day and required sedentary work or activity after 2 to 3 days. And when it's compared to the invasiveness and the hydrostatic pressure, which is among the 3 techniques, the amount of the invasiveness to the tissue, it's maximum with the tubular, and the complication of the hydrostatic pressure due to the fluid, it's higher in the UBE technique, because the UBE is open, while the monoportal is a closed system that's carry the risk of the hydrostatic pressure less. So when it's come to the learning curve, I know that this is the big obstacle for everyone who want to start with the endoscopic spine surgery. But in the monoportal, especially the interlaminar, I'm talking, that's the 80 case you can reach the proficiency milestone, and the target efficiency, which is the time, it's almost 60 minutes. But I think that in the expert guys, this time is too much, especially for straightforward fresh disc. When you are talking, you can tackle it and finish the surgery within, let's say, 15 to 20 minutes. So I think that's the steep learning curve when it's compared the interlaminar with the UBE monoportal with the UBE monoportal will win, and also superior stabilization of the blood loss is even low, because we did a study with Ahmed about UBE. There is a gap time between you start the surgery until you finish, till you reach the disc, which is creating the space, and the other, which is almost, let's say between 5 to 15 to 20 minutes. And this is in the interlaminar, you just face the ligamentum flavum and start to do the job. So when it's come to the technical performance metrics, I think that's the fluid system, the invasiveness, the hospital stay, all go with the monoportal endoscope, as you see in this, let's say, table. So the vision among the tubular, it's not only, let's say, the trauma that's happening due to the squeezing or the pressure effect of the tube itself, but again, the illumination is amazing when it's come to the endoscope. You can visualize, let's say, the scope with the 4K. I know that there are some microscopes still support the 4K, but the blood loss is less when it's compared to the tubular. So when it's come to the, let's say, monoportal and biportal, I think it's clear among the AO spine guys, they regard it as the UBE is endoscopic assistant rather than the pure assistant. I don't know why, actually. I disagree with them. Still, the UBE is a good option, and it's endoscope. But I think that's the concept of biportal, and the tissue damage might be the cause. When it's come to the clinical performance, all go with the monoportal, and also I think that's, for me, the UBE is a bridge, but the monoportal is the destination when it's come to the evolution in the endoscopic spine surgery. And the leader of the
Wopage and Ital in 20.
Yeah. So I will review some cases, which is, I think that let's say carry the effect and the impact of the monoportal. This is a 37 years old female, right side radiculopathy for 3 months, weak dorsiflexion, and this is the X-ray, and this is the MRI. So I chose to do the, let's say, monoportal using this system, and which is I think that's similar to the tube when it's come to the vision and the stepwise, and this is step that you can remove the let's say the disc material and ensure that you do decompress the root itself with in a fancy way like this video. So another cases, which is a 35-year-old female, history of endoscopic discectomy 8 months ago. This is another indication that's recurrent disc after let's say previous endoscope. See the MRI of the lady, almost completely, let's say, virgin area in the posterior muscular area. So I revised her weight is almost 140. So I don't think that the tube will work here in this case. So I choose to do interlaminar endoscopic discectomy, and this is it wasn't easy at that time, but it can be done actually. And this is the picture that you saw. It's a bloody field, and it's not normal field because it's a revision. So I removed the sequestrated piece, and let's say without any intervention that's required more instrumentation or even the damage to the collateral muscle. And this is the way that I did for this lady. And the third case, which is also interesting, 75-year-old diabetic hypertension and chronic renal failure, BMI 40, severe back pain for 4 weeks, no response to conservative ESR C-reactive protein. And this is her MRI. As we see, that's at the level of the 2-3 is almost, let's say, pus collection in this lady. No one can give her an anesthesia, so we decide to do infiltration, local anesthesia, and the treatment done by let's say transforaminal endoscopic debridement and let's say fixation. And see, this is the way that we introduce the needle, and see the pus how it's come from the disc, and then we did debridement of the disc space, and followed by fixation under local anesthesia, which is, I think, that we solve the problem of the lady without any jeopardizing, let's say, her general condition. So the final case, 45-year-old, back pain, lower limb radiculopathy, L3 dermatome in the right side, and weak knee extension. See, this is the MRI, as we say, a well-contained disc, partially sequestrated at the level of the 2-3. And what I did, I prefer in this level to do, let's say, transforaminal, which is let's say the site that's described well in this picture and the video. And this is the disc material that already sequestrated and removed by let's say transforaminal approach, which is a fancy approach in this case to avoid manipulation of the neural tissue. So I think that's from my side. The monoportal endoscope is a real spine endoscope. It offers different approach. You can do, let's say, interlaminar, Wolsey approach, transforaminal, and even in the transforaminal, there is extraforaminal. Many approaches can be done with minimum tissue damage. Expand indication with optimization the learning curve. That's why I recommend to start with a simple disc and then build your let's say cases, and then after that you can expand the indication accordingly. Tubular was the revolution. UB is a bridge, but the monoportal is ultimate destination of the tissue preservation. Thank you.
Thank you, Ghawzan. That was very extensive and elaborate on monoportal. Now, one of the criticism of monoportal, and especially like someone who does it, like you who does everything, is the expenses you need to occur to do these cases. So how will you counter that to the advantages that monoportal gives you?
Actually, as I told you, I'm living in the environment that's different from European, American. It's almost the same environment that's in India, let's say, because the cost is determined factor. So that's why I'm not doing only monoportal. I'm doing biportal. I'm doing everything. But I choose the case accordingly. So for fresh discs, straightforward, I prefer to choose monoportal, because I don't think that's Monoportal will be a good solution for complicated disc, calcified disc, stenosis. In the Biportal, I'm using, let's say, the same instrument, basic instrument of the spine, so there will be no more breakage or negative feedback from the instrument side when it's compared to the Monoportal. For me, it's work, and I think that in this scenario, it's the best that's worked for me. And we all agree that for stenosis, is still the UBE and the tubular superior to the Monoportal, and even in case of fusion.
So what about those who want to start Monoportal? What will you recommend the ideal starting case?
I think that the ideal starting case, you started from septum indication for surgery, read the MRI in details, because there are lots of MRI on, especially when you read it on CD or online, it's better than on let's say on file. And the point that's try to choose, let's say the fresh disc at the level of 5S1 posterolateral disc. This is an ideal, we all agree, and avoid the upper lumbar cases, especially let's say L2, 3, 3, 4. And when it's come patient presented with a chronic septum, keep in mind that the upper lumbar spine disc prolapse almost, let's say in majority of cases, is calcified and chronic, so it's not ideal to go. So 5S1 fresh disc posterolateral is the ideal case to start with the interlaminar.
So one quick question to Dr. Arvind Kulkarni. What will you tell to guys, who are yet to, adapt to Monoportal? I know you adapted to Monoportal in spite of you being, one of the pioneers in tubular. So what was your driving point to go and adopt a new technology altogether and include Monoportal in your surgical skill set?
So I didn't hear you because it was frozen for some.
Okay, okay.
Yeah.
My question to you is, what will you tell the guys who are still reluctant to start Monoportal? I know you are someone who is one of the pioneers for tubular, but you adopted Monoportal and it is now part of your skill set. So what was the driving point to adopt Monoportal?
So one was, I was doing, monotonously tubes for last 20 years. I wanted some challenge in my life, so I wanted to try something new. Something exciting. And second is the patient's demand. See, there are patients who are very well read. They come with pictures. They want to do discectomy under water. So I should be ready to do what the patient wants. So gone are those days when you try to impress upon the patient that you should follow the path what you tell them. But so it's basically consumer demands. So you have to modulate yourself accordingly. And I didn't want to lie to them that tube is, there's nothing different from the tubes, etc. Actually, outcomes wise, it doesn't make much of a difference. I use a 14 tube for discectomies, but I didn't. I wanted to be very fair with them. So if you want to do it with the Monoportal, let it be. Let me do it with the Monoportal. So I had to train myself. So it was a revolution when I started doing it. I even do stenosis, one level stenosis with the endoscope now.
Okay.
I think patience matters. So actually, it is good for newcomers. Newcomers have few cases, so they sometimes have just one case the entire day, and this takes time. So it is best when you start it afresh rather than when you already settle in practice.
Okay. Thank you, Arvind. Thank you, Ghawzan. Raymond, you can take over from here.
Okay, so are we taking questions for this, or do we have any audience, or we just go to the next speaker? Okay, so the next speaker will be Dr. Ahmed, and he'll be talking on Biportal. So instead of Monoportal, we have Biportal here. So pushing the limits of endoscopy using unilateral UBE endoscopy. Dr. Ahmed, the floor is yours.
Okay, thank you for inviting me for SMISS webinar. Okay, I'm talking about today about the Biportal, and how we can push the boundaries of endoscopic spine surgery by using UBE. So the evolution of spine surgery has a goal. So what the goal is less tissue damage and faster recovery. So we shifting from open surgery, microscopic surgery, tubular surgery to endoscopy. And the endoscopy, I think, now is the current frontier of spine surgery. I did most of the procedures, and now I'm in the endoscopy era of my life. Because endoscopy, we thought that endoscopy is start changing the open and old-fashioned surgeries, and those open surgeries will replaced with MIS by 2040, and by 2040 it is expected that no more open surgeries will be. MIS will replace everything like gasoline and electric cars do now. So regarding monoportal endoscopy, it has the strength that it has the minimal tissue damage, but there is a lot of limits with monoportal endoscopy. The limited instrument maneuverability and the crowded working channel and difficult bleeding control. Regarding UBE, it has two portals. It has continuous irrigation, and you can do a free triangulation. So you can feel free during your surgery more than monoportal that guide you through one site of surgery. The core concept of UBE is that it is microscopy-like freedom with endoscopic advantage, because you can see everything very clear and very big during surgery, and the freedom like doing your surgery with microscopy, wire tube, or micro retractor. You can use you use your instrument dynamically, and it has very wide surgical field. You see in this video there is a crowded instrument in a small field that you can't do with this put these big instrument relatively in monoportal, but you can do with UBE very easily. So UBE expands our indication of surgeries because it has better contralateral access. You can decompress the contralateral site easily. You can reach the contralateral foramen easily, and you can dive in the contralateral foramen easily. Improve your decompression. You can take the ligamentum flavum in one piece from the upper margin to the lower margin, from the upper lamina to the lower lamina of that level, and it enhance bleeding control. You can use all sort of bleeding control to stop your bleeding, and you get your dry field. The indications beyond the Uniportal, you can do bilateral decompression easily, central stenosis easily, recurrent disc can be done easier with Biportal, at least in my hands, and you can do multi-level cases with multiple small incisions, and you can do also Wilsey approach. You can target the extraforaminal area as shown in this video, but with less bleeding that we see always with the classic Wilsey approach. And there is advanced application of the UBE, like fusion, UBE TLIF fusion procedures by transcampion approach, and tumor biopsy, and you can excise small intradural tumors as well, and infection debridement with UBE. So if you come to UBE versus monoportal, there is greater instrument freedom, better bleeding control, and expanded complex indications. Technical advantage, you can use standard instruments that already there in the theater, better ergonomics with the instrument and the environment of the surgery, and larger working space. And if I calculate and follow my progress in developing my new techniques in endoscopy, and I replaced only with UBE, you can see that in 2023 to 2025, there's increased up to 70% in my last year that I do surgeries with UBE. But there is also some challenges in UBE, like fluid management. Learning curve, still there is a steep learning curve, but it is better and easier than monoportals, and there is orientation difficulties. But I see that these challenges and difficulties will fade with time, because the next generation of fellows will be very oriented on the endoscopy and the new technique more than we as an old generation maybe of spine surgeons. There is also complication of UBE, but I see that it's complication less than monoportal or open old-fashioned surgeries. For dural tear, really in my cases and my record, I have 0 endoscectomies, around 3% in decompression, but 7% dural tear in my open and instrumented fixations of dural tear in the last few years ago. Also, there is epidural hematoma. It's a complication of UBE, but with the good management of bleeding with radio frequency, you can overcome this complication. And I always put a drain with UBE and pick up the drain 6 hours or in the next day for decompressions. Neurological injury, it depends on the learning curve. I have really one case of foot drop developed after discectomy, but usually I have the neurological complications after UBE in higher level of lumbar spine, but it is usually a transient weakness of the quadriceps muscle, especially at L2, L3, and L1, L2 cases. There is a risk in all endoscopic spine surgery of increased intracranial pressure, especially if you have dural tear. But according to my experience with surgeries, even without dural tear, if I set the fluid pressure to 110, the patient start developing headache. I noticed that when I doing discectomy or decompression surgeries under spinal anesthesia, the patient shouting that he has headache when I reach 110 mmHg during surgery. So I usually use higher levels of pressure only to control bleeding, then come back down to 70 or 75 of fluid pressure. And this case, I show you that there is dural tear, multiple dural tears that needs really repair. So what is the future directions of UBE endoscopy? There will be a robotic integration with the endoscopy. AI will come to the field of endoscopy, and there will be integration of AI with the endoscopy to check the sites of bleeding, so it would be easier for you to pick up the vessel that bleed and you can stop that bleeding. And also there will be 3D endoscopy that will be integrated maybe with endoscopy and navigation. So my take-home message: UBE bridges MIS and endoscopy, expand safe surgical indications, and represent the next evolution of endoscopy and MIS. And thank you.
Thank you. That's excellent presentation. Do you do Monoportal as well?
Really, I don't do Monoportal. I do
Okay.
only UB.
Okay. I'm just wondering about the learning curve between the two. For say a new surgeon who doesn't do either, which do
Really,
you think would be the easier learning curve? Because I think a lot of the UBE surgeons are saying the learning curve is actually easier because you have two hands, so it's just getting used to the triangulation. Whereas the monoportal, the learning curve could be harder because it's actually harder to physically retract and away the nerve root, and because of limitations of geometry. Yeah. So, but what would I'm asking both previous speakers, so Dr. Ghawzan as well. Which do you think is the harder technique to learn for the budding
I
endoscopists?
think that for me, maybe UBA is very easy because when I start doing UBA, I didn't shift my early cases to open or tubular surgeries. So I didn't
So you went
face,
straight from open to UBE?
I come to straight from open to UBA directly. And
So no tubular?
not tubular.
Oh, okay. Interesting.
Fortunately, I didn't shift my early cases to open or tubular surgeries. When I asked my friends in Turkey, Mohammed Aydogan, he told me that he shifted his first few cases to open surgeries because they face difficulties with the bleeding or dural tear. So I think that UB is an easy tool that with a very low incidence of shifting to the surgeries to open surgery in case of any complication you got during surgery.
Yeah, I think that if you let's say I'm doing all the technique, I think that's the easiest learning curve is interlaminar monoportal, then UBE, then after that the transforaminal. This is from my perspective. Yeah.
Yeah, Ahmed, one question from my side. Do you really need the UB scope, or can you use the scopes which the knee guys use to start UB?
You can use the knee scope really, but I think that 0-degree lens is the best. I use both 0-degree and 30-degree, but for knee arthroscopy, always surgeons use 30-degree lens. But I see that working with 0-degree lens is very much easier than do with the 30-degree. So you can use the same scope, that the cross scope. I always use the same instrument for knee scopy, but I changed the lens only with 0-degree.
Do you use the 30-degree for when you go across to the other side for the
It would be very helpful if I change the lens to 0-degree to go to the contralateral side. It would give me better view for the foramen. But for ipsilateral decompression and the ipsilateral disc, usually the 0-degree is the best.
Any questions from anyone to Ahmed Qutub? So I think thank you, Ahmed, and please stay back. And so let's move ahead, and we go back to Dr. Muhammad, who is a excellent spine surgeon from Jordan, and Muhammad will be talking about tubular approaches indication and clinical outcome. Over to you, Dr. Mohammed.
Thank you. So can you see my slides?
We can see your slides.
Yes.
Go ahead.
Okay.
Yes.
So thank you for invitation. I will get back one step from my friends Ghawzan and Ahmed and talking about the tube. I have no disclosure related to this talk. So an overview about this talk, this is just what we can do with the tube approach and some clinical outcome with some literature review, although most of the literature is old, and how we use the tube in MIS TLIF. So a tube, I think this is the first tool in MIS to use a tube, and we have to remind you that we have to do the job. We don't accept any suboptimal outcomes because we would like to do that as MIS. So the idea of MIS to do this intended surgical goal with less collateral tissue damage that will give our patient less morbidity and rapid functional recovery. Actually, the tube can be used in lumbar microdiscectomy, although it is not popular nowadays. We use the endoscope in simple discectomies. I think the tube still have a role in multi-level lumbar decompression and multiple spinal canal stenosis because this may be faster than the endoscope. And sometimes we use it in posterior cervical foramectomy plus minus foraminal discectomy, and we still use it in MIS TLIF. So this is one of my cases. This is a 78-year-old gentleman with severe bilateral leg pain, failure of conservative management, and on the X-ray there is no instability. And as you can see, there are multiple levels, grade D and C, mainly L2, 3, 3, 4, and 4, 5. You can see 4, 5 is grade D stenosis. And you can you can open the floor for discussion if you will refuse, how levels, if you will decompress. But I think all of us agree that these 3 levels at least should be addressed by decompression. So open laminectomy has been considered the reference standard for these cases. Less invasive like midline retaining and posterior decompression techniques have been also introduced, and they have shown similar effectiveness as traditional laminectomies, but with shorter length of hospital stay and less invasive nature of the procedure. And mechanical point of view, we know if we do total laminectomies, there will be no disability, or there will be no increase in the motion of the segments. But we still we would like to keep the spinous process and the midline structures, just the lever arms for lumbar extension. So for these patients, we did the surgery using the tube. As you can see, we have very nice image. This is a video. If you can see it, we'll go just fastly. This is a lamina. We dilate the muscles. We're trying just to avoid going it through a heavy part of the muscles, just only a small strip of the muscles, and then we go with a drill. So as you can see, we have to deframe it, then we start with drilling. And I prefer, as you know, to go proximally until the attachment of the ligaments. And once you are on the attachment, you start to remove the ligaments through the microscope. And I think this should be fast. And this is how it looks. So as you can see, using the tube, you can do a very nice pedicle to pedicle laminotomy decompression, and you can see both roots nicely within the microscope. And how it looks, we can see the root now, and we are happy with this outcome. So if you look at the literature, most of the literature talking about the tube is really old, 10 years and more. This is a comparison between 3 different minimal invasive surgical technique for lumbar spine stenosis. As you can see, we have the unilateral laminotomy or bilateral laminotomy and bilateral laminotomy plus spinous process osteotomy. This is from Norway, more than 400 patients, 16 public hospitals, and they showed that there is no difference in the 3 procedures. So I think most of us, we are doing the unilateral laminotomy nowadays if we would like to use the tube. Another way to use the tube is to go through if you can see here, if you can go through the spinous processes. And I don't like this procedure because the idea of the tube to avoid any midline structure interruption. So still we can use the tube as this paper, but I don't like to use it like that. So if we look about minimal invasive operative management for lumbar spinal stenosis, this is also maybe an old paper which compares standard open posterior decompression to minimal invasive microendoscopic approach for bilateral decompression. And this technique has been shown to provide symptomatic relief equivalent to that of open discectomy with significant reduction in operative blood loss, post-operative pain, hospital stay, and narcotic usage. Other way to use the tube is the posterior cervical discectomy. The indication mainly cervical radiculopathy with failure of conservative management. If we have a disc herniation, osteophyte, or foraminal stenosis producing root compression, and if we have no evidence on stability. So this is an example of foramentum, posterior foramentum using a tube or minimal invasive, although you can use also the endoscope in these cases. And this is what we call it the Y-shaped facets and both laminas. This is the area that should be removed when you do these procedures. The contraindication to go from the back in these cases are central stenosis, instability of the patient have significant mechanical neck pain. The advantages, it's maintain the function, the motion segments, minimize the adjacent levels. As we know, if we use an ACDF from the anterior, that will increase the adjacent level problems in the other segments. You can see the root nicely in this procedure, and we can avoid the anterior complications like recurrent laryngeal nerves and Turner syndrome, and avoid post-operative neck immobilization. This is a day case procedure. Patients, sometimes they can go home the same day. The disadvantages are post-op neck pain, inability to address central decompression, need for neural retraction. So you have to mobilize the root just to remove the disc from behind, prone position problems, and risk of instability and risk of recurrence. The outcome is good. So 91% we have excellent outcome, 6 good and 2 fair and 1 poor. This is also an old paper since 20 years. I still use it. The last case I did was today morning. The patient just is happy and went home just 6 hours after the surgery. So this is another case. This 36-year-old history for 5 open discectomy 6 years ago. Presented to ER with acute right lower extremity pain numbness after lifting heavy object. He was shouting the ER. His exam showed some weakness, 1/5 over EHL. We admitted him because he was in severe pain. We gave him some pain medications, but still weak. So we went through the discussion with the patients, either to go with a decompression again by tube or by endoscope. We have a surgeon, a colleague, he do that by endoscopic techniques, and or to go with and to do fusion. And because of, as you can see, he's still young, and he has significant back pain before this incident. And after just discussing with the patient, we advised him to go with MIS TLIF. So it is a minimal invasive technique, avoid scar tissue. We go through a virgin area, which is the facet joints. It's allowed direct decompression and removal of down migrating piece in one position, good alignment and anterior support, and good fusion rate. So if we go back to the history of TLIF, the first time interbody fusion was presented in 1952. Harms introduced open TLIF in 82, and Foley and Lefkovich introduced MIS TLIF 26 years ago. So it's really an old technique. And when we call it TLIF, we use a microscope or endoscope with a tube. If we start to use loops, then we call it mini open, if we have a paramedian incision. So the idea to have small incisions, you use the tube or endoscope just to do the decompression and to insert your cage. So the benefits of MIS, as you know, it's minimal invasive. So it's minimize soft tissue disruption, achieve bilateral decompression, and achieve indirect neural decompression. We start usually with cannulating the Jamshidi needle, cannulating the pedicles, and this is how the patient looks like. We have 3 incisions, ipsilateral long incision about 4 centimeters. We insert K-wires, and the other side we just insert the screws, and this is how it goes in. We sometimes use a rod to do distraction in one way, but this is an optional. And this is how we use the tube in MIS TLIF. Usually, we would like to land on the facet joints. In these cases, if we not aiming to do a decompression, because already this patient segment is decompressed, and the best position for the tube for me is parallel to the disc. The upper side of the disc, the upper side of the tube should be parallel to the upper side of the vertebra. This is the optimal position for me. And if you look here, you can see the facets, and you can see the facets is clear here, and you can see the spaces here. And after that, we start directly with the facetectomy. And after facetectomy, you can just do some decompression to see the traversing root, and you can see the huge disc. If you retract the root, then we use the in the blade preparation and the inserting of the cage. And after that, as you know, we just insert the screws. So this is my patient. Just his sister sent me a message after maybe 3 hours after surgery without any support, and he is discharged second day. So my take-home message: the tube is still there. Is used most commonly in lumbar decompression in multi-levels. Symptomatic relief equivalent to that open discectomy with significant reduction, operative blood loss, post-operative pain, hospital stay, and narcotic usage. Still, it's a good tool, although endoscopy now is very popular. Most of the surgeons would like to go and learn how to use the endoscope, but I think a tube still have a wide range of usage. Thank you.
So,
sorry, yeah, thank you, Dr. Mohammed. Thank you. I was muted. Do we have any questions from any of the panel regarding tubular?
Yes, so for the benefit of the viewers, how would you manage bleeding and excessive bleeding, and how would you manage dural tears?
So dural tears usually, if it is not measured, because sometimes we have dural tears very far from away, so sometimes very difficult just to suture it. Always I would like just to have a stitch or two in that tears. Some of my colleagues just leave it because the muscles will just back the tears. I did that maybe 3 or 4 times with no complications, but most of the time would like just to put a stitch there, and you can do it through the tube. Regarding the bleeding, most of the bleeding is happening to the foramens, so it's easily to use a bipolar there.
so what about others? Do you regularly repair your tubular dural tears? Do you open it up and repair always? What about Dr. Arvind?
No, I remember only one case where I had to open. This was one of the first few cases that I did. Later on, I realized that they don't usually trouble you because it is a watertight portal through which you pass the tube. So there's a tamponade effect once the tube is out, and usually if you put a tight suture. I use a ethylon mattress when I have a dural tear. I don't take a subcuticular stitch, and tight dynaplast dressing that usually serves the purpose. They don't even complain of headache, nausea, etc. And you can mobilize them the very way you mobilize any other patient.
Even the same with us. We never. Now I believe opening it up makes more dead space.
Yeah.
Only thing we ensure that the rootlets are in. That is one case where I could not put back rootlets. I had to open. Otherwise, if the rootlets are in, we never open it up. It's better to the tamponade effect of the muscle falling back, and the dead space is hardly there. We have never had issues with dural tears in tubes.
Yes, agree with that. Yeah.
And when the rootlets are out, you should not panic. What you should do is just cover it with a patty, relax, take a few breaths, and go around and decompress. Complete your decompression. Once you complete your decompression, once the dura expands, it is easier to get the roots into the sac.
Agree. And the other thing to add to that, we also try to relax the nerve. So you just, if you have put the legs in, some sort of a, flexion, or they're tight, just relax them the rootlets become much more easy to go in. So that is another thing which we do. And I think that is the versatility of the tubes. You can really tackle them. So that has been our experience as well. About the types of the tubes, like Dr. Mohammed, do you prefer the fixed one, the expandable? Any difference you see between
No,
the
usually I really like the fixed one because it works very well and you can just move it without just it's just a stay for that. I don't think we have to use the expandable ones. This is my experience at least.
Just one comment, Dr. Mohammed, that interspinous, docking the tube in the interspinous, between the spinous processes, it is paradoxical because you're cutting the interspinous ligament. At the same time, it doesn't go with the philosophy of MIS, but at the same time, for upper lumbar levels, maybe it's a good idea.
Yeah,
Sets
I
us
agree with you. I never use it, but I found it in the literature.
L2,
So
3,
just to
L1,
mention
2.
that, yeah.
I actually do the interspinous approach for the upper lumbar because the interpedicular distance is so close that if you try to remove it via the lamina, you'll end up causing a pars defect because the facet joints are so close together. If you do try to go and resect some of the inferior lamina, often you'll end up with a pars injury. So we look at the MRI films beforehand. And in the upper lumbar, I do the interspinous approach. I haven't seen any instability, so I don't think the interspinous is a problem. Frequently in spinal stenosis patients, it's actually sagging inwards. It's actually that ligament's actually causing the compression, so you have to remove it anyway. So when we're removing the ligamentum flavum, the whole thing is actually folding inwards and it's pushed in by the interlaminar ligament. So it's often going to be decompressed if you're doing an adequate decompression. But I do find it useful for the upper lumbar using the 14 tube. And even with the 14 tube, because the spine is so collapsed, often we have to remove some of the spinous process to get in via the interspinous process approach because the tube won't dock or you'll try and push it in and it'll slip left or right.
I think if you remove,
sorry,
I think if you remove the ligament, then the flexion between the segment will increase. That will increase the range of motion of that segment, and that may lead to degenerative maybe changes years later on. So I don't know. I don't have any experience with that.
Yeah, I have. I've done those before because it's better than causing a iatrogenic pars defect.
Yeah. Okay.
So I think if we don't have any more questions, let's move on to the next speaker. The next speaker is Mr. Dr. Shyam, a very good friend and a dear colleague. And he will talk on one of my favorite topics, which is the OLIF, the ATP evolution. Over to you, Shyam.
Thank you very much, Ayush, and thank you, Arvind and Raymond. Thank you to SMISS for working on this and arranging this. And thank you for giving us the opportunity to connect with our friends and our colleagues as well. Mohammed, can I ask you to stop sharing your screen? All right. So we're going to move away from all the discectomies, decompressions, though Mohammed did touch base earlier on some instrumentation talking about MIS TLIF, which is a wonderful surgery if it's done the right way, obviously. But we're going to talk about the use of anterior approaches nowadays in adult spine deformities. So those are my disclosures. I consult for a few companies. I sit on the advisory board of others, but none of those are related to what I'm presenting today. Now, if we are to talk about look up the dictionary and look at the word gold standard or benchmark, I'm pretty sure no one has any of those nowadays. We don't have dictionaries anymore, but it's basically something that you compare other stuff to. And it's very difficult in 2026 to call this the gold standard because those adult spine deformity surgeries are very morbid. They carry a lot of complications and they are not as benign as we think they are. And don't take my word for it. This is the paper that was published by the International Spine Surgery Study Group a number of years ago in 2015, where they included almost 12,000 patients. And you can see here that in adult spine deformity patients, 55% complication rate. So 1 in 2 patients is going to end up with a complication. There is another paper that was published by the same group that included almost 300 patients. And you can see here that up to 70% of patients experienced at least one complication within 2 years from surgery. Now, they were, it was said that we were over-reporting some of the complications by reporting some complications like dural tears and wound dehiscence, wound complications. But even such simple complications can give you some sleepless nights and can give you more gray hair over time in your career. And it's not something that you want to deal with as well. Now, if you take a look at the Scholar risk study that was done a number of years ago, and that study was very important because it showed us that there are some particular variables that are associated more with complications. And those are age, especially when patients are above the age of 69 or 70, and the introduction of a major osteotomy like a PSO. Now, we don't pick our patients, and probably if you're operating on an adult spine deformity patient, he's going to be older anyways. But you can definitely do something around that PSO that prevents you from going into that major complication. The problem is the population is aging, and we're expecting by the year 2050 that 1 in 4 patients that we're going to operate on is going to be above the age of 65 anyways. So we are expected to do more and more of adult spine deformity cases in the near future. Now, some of you would probably say, well, those patients are already very frail. Those patients are already very old. If we're having a complication rate of 70%, so what's the point of operating on them? We can just leave them to natural history. And instead of putting them into a large surgery, a big surgery with big complications. But we also know from the literature that those patients who are frail are the ones who improve significantly after surgery. So we need to find that balance between offering those patients surgery while decreasing that risk of complications. And the question is minimally invasive surgery any better when we're dealing with adult spine deformity? So there is always people, whenever we're giving those talks, that would tell you, you cannot use it for major cases. It has to be a very minor curve. It's something that cannot achieve a good sagittal correction like what you achieve with a major osteotomy, like a PSO or a VCR. You cannot put your iliac screws in an MIS technique. And there is always someone who stands in the middle and says, pseudoarthrosis is higher definitely in MIS surgery. Or there is no long-term data, though I disagree with this. Into 2026, we have enough data now that can support this. So if we take a look here at a number of papers that were published by a single surgeon from a single center, Cedars-Sinai, you can see by Neil Anand, who's a very good friend of Ayush. You can see that over the years, he was very interested in achieving good corrections by doing anterior approaches in adult spine deformity, and he published very good data over the years. Now that pushed the ISSG to say, well, maybe it's not fair that we are comparing apples to oranges. Like we looked at the complications of adult spine deformity on all of those patients, whether they are operated with an MIS surgery or a hybrid surgery versus an open surgery, and we didn't subcategorize them into different groups. And once they started having that thought, we started to see a gush of a number of papers talking about the use of MIS in adult spine deformity. And I'm not going to bore you with all the papers here. I'm just going to take a couple of those. So if you take a look over there, comparing MIS versus hybrid versus open surgery, and by MIS here, we're talking about an anterior approach, basically an ATP approach in a combination with percutaneous screws posteriorly, hybrid surgery that included both, and an ATP approach together with some osteotomies done in the back posteriorly, and a classic open technique that included posterior osteotomies as well. Now you can see that for all 3 groups, all of them did improve in their functional outcomes and their pain scores from preoperatively significantly postoperatively. So we know that adult spine deformity correction, whether it's done through an open or hybrid or MIS approach, does work and it improves the functional outcome of patients. But when we jump to complications, which is the part that we're really concerned about, you can see that MIS is significantly superior when it comes to the number of complications or the incidence of complications in adult spine deformity cases. Now, what about the nemesis, proximal junctional kyphosis? And we all know that the SRS nowadays defines proximal junctional kyphosis as an increase in proximal junctional angle of 15 degrees. It used to be 10 degrees before, and now it's 15 degrees. And the SRS in 2021 introduced that very strong statement that it's the single biggest unsolved problem in all of spine deformity. And this is a huge statement to be introduced by the SRS when it comes to PGK or PGF. Now here I want to introduce you to one of my disasters. So this is a case that I operated right out of my fellowship. And you know, when you finish your fellowship, you kind of grow some extra muscles and you feel that you're invisible, and you can conquer the world and you can do whatever you want till you get one of those cases and you get really humbled and your ego goes all the way down. So this is a 65 years old female patient with severe lower back pain, bilateral radiculopathy. She presented to me with those x-rays. So she had a previous L1 to L5 fusion, and you can see that she's developing clearly a PGF that's happening over there with a pull out of the screws. And I did for her a CT myelogram, and you can see that she has pseudoarthrosis all over the place with loosening of the screws in the proximal segments and pulling out of the screws. So I thought this is easy. I'll take her to the OR and extend her all the way up to T10, and that's what I did. And I was very happy with the outcome. We were actually high-fiving each other in the OR that we achieved a wonderful job. Now, I wait for 6 weeks, and she's coming into the clinic. She's very happy, has a big smile on her face, and I send her for x-rays. And take a look over there. So at 6 weeks, she's already developing a proximal junctional angle of 37 degrees. Now, she was very asymptomatic back then, so I called everyone I know. I called my mentors, my previous program directors, and I got the idea that put her in a brace and give her some anabolics or something, and she's going to stabilize over time. Now, obviously, I was naive because here she is at 9 months post-operatively. Her proximal junctional angle is at 53 degrees, and now she is symptomatic and presenting to the emergency department with severe pain and some signs of thoracic myelopathy as well. So I took her to the OR. I extended her all the way up to the upper thoracic spine, and I used that quad rod construct. And whenever you're using those rod connectors, try to use a quad rod construct. You'll be surprised the number of times you go back and you find those very loose. So always try to have maximum stability whenever you have those connections. Now, she was very happy. She did fairly well, but that didn't last long because 8 weeks later, here she is, presenting again to the emergency department. I get that call from the hospitalist saying, oh, your patient, Mrs. X, is in the emergency department, and she's showing signs of myelopathy. And he was very excited that he could diagnose myelopathy in the ER. Obviously, I wasn't that excited on the other side. So here again, I went and talked to the family and had to extend her all the way up to the cervical spine. Now, luckily, she did fairly well, and she managed to stabilize. And you can see that over that period of time as well, she also developed that hip fracture over there that was managed by my colleagues with some of the proximal femoral nails as well. But the point here is proximal junctional kyphosis is real, and we know from today's literature that the incidence is much lower when you're using that circumferential fusion. And that's not just showed by the data of Neil and Ant from Mount Sinai, it's shown by the data of the SRS and the International Spine Study Group that you can decrease their incidence of PGK by doing an MIS technique instead of going for open surgery. And the idea for this is that you're not disrupting much the posterior structures. You're achieving that harmonious physiological restoration by getting some correction at every single level that you introduce a cage in. You're not getting that acute correction that you get over a PSO, and you're not doing much of an inside to bending that we honestly do a lot with open surgeries as well. Now, we also know as well that hardware failure nowadays from the data is much, much lower in MIS techniques and ATP surgeries in comparison to open surgery as well. So that's another benefit of this. Now, I want to introduce you to, whenever we're talking about lateral approaches, surgeons tend to say, well, I'm doing a transpsoas approach and I'm not achieving that much of a correction. So what's the point of just introducing some fancy cages in when I'm not getting any correction? PSO is the way to go. Open surgery is the way to go if you want to achieve major correction. And I kind of agree with them because that's true with transpsoas approach, not with ATP. because those two surgeries are absolutely different. So if you're doing a direct lateral or transpsoas approach, this is what you do. You're basically landing in the middle of the psoas. You're doing that middle third discectomy. At this point, you're very happy with what you achieved. You're trying to introduce a big cage in. You start seeing on your x-rays in the OR that you're getting some correction of the lordosis, but you're very needy as a surgeon and you want to achieve better. So you start getting some bigger cages in as well, or bigger trials in. And that's why you don't have any much of a stretch in the front anymore, because you have to stretch that ALL to the maximum. And that's why in those surgeries, you're not getting much of a correction. As a matter of fact, at 6 weeks post-op, in the majority of those cases, you're getting subsidence as well. But the difference with ATP is that since you're landing anterior to the psoas, so you're doing the exact same steps, but at this point, when you have already stretched the ALL to the maximum, you have the access to the AL to take it out completely. And then when you start doing those using those hyperlordotic cages, that's how you achieve that correction. That's how you achieve that correction that's always similar to the PSO. And that allows me to move from something as flat as this to a proper lumbar lordosis like this. And you're not going to be able to do that with a transpsoas approach, because you're not going to be able to rip that ALL out. So let me show you another case here. This is a 67 years old male patient with a history of L3 to L5 endoscopic decompression a year ago, despite the fact that he was presenting to his initial surgeon with severe back pain. And according to him, he didn't improve much after the surgery. And that kind of makes a lot of sense, because if you take a look at his x-rays, he has degenerative scoliosis in the lumbar spine with some lateral listhesis on those AP x-rays. And those are his parameters on the long-standing films. And this is a patient that we took to the OR, and we did for him a 3-level ATP approach. And you can see the amount of correction that he can achieve with ATP. You can see that you can correct his sagittal profile together with correcting his coronal profile as well. Here is another case. This is a 66 years old female patient who had one of those very old L4-5 posterolateral fusions. And you can see here that her sagittal alignment is way off, and her SVA is probably like 10 centimeters anterior to her pelvis. Now, this is a patient that through a single incision and L5S1 ATP was done together with few lateral cages that were fired over there, and now her head is on top of her pelvis. And all of this without the need of going into some major osteotomy. I'm not saying it's incorrect. If major osteotomy is work in your hands and you're happy to deal with the bleeding and happy to deal with the complications, that's totally fine. What I'm trying to say is there is another way of doing this with fewer number of complications if you master the technique, obviously. And I leave you with this case. This is a 65 years old female patient. And I'm not saying that this is the everyday case. This is a patient that presented to my clinic several times, and I was kind of pushing her away over time because I was worried about the number of complications that I can get with her. And she used to work in the hospital as well. So I had a previous laminectomy and discectomy, actually a couple of procedures before, and she has tried everything. Steroid injections, physical therapy, RFA, some voodoo, magic, everything you can think of. Those are her x-rays. And you can see here that she has almost like a kyphotic lumbar spine, and you can see that her coronal profile is way off with a lot of derotation in the lumbar spine as well. Those are her long films, and I'm just going to jump all the way here to the MRI scan. And unfortunately, I don't have the axial cuts of the MRI, but you guys can imagine what's happening at every single level over there with significant lateral recess stenosis and foramen stenosis as well. Now, this is a patient that we also took to the OR, and through an ATP approach with a single incision, we managed to do her all the way from T10 to pelvis with an interbody instrumentation, all the way from the thoracic spine all the way down to the lumbar spine. So you can achieve some major corrections nowadays with the right tools and the right technique with MIS. Not every major case needs an open major osteotomy to correct the lumbar spine. Now, despite all of this and despite all the techniques that we have today, Neil Anand, a number of years ago, decided to see where are we today in terms of adoption of MIS in adult spine deformity or ATP approaches. So he sent that particular case to all the SRS members. And he told them, if you have that patient in your clinic today, how would you treat him? Now, interestingly, that 70% of patients elected to go with open surgery. almost 25% of them elected to go for a hybrid technique, and only 7% decided to go for an MIS technique. And that tells you that we still have a huge room for better education and teaching and training surgeons on how to use minimally invasive approaches, particularly ATP, to be used in adult spine deformity today. So bottom line is the population is aging, and we are expected over the coming few years to operate more and more of such patients. The techniques that we have today with MIS and ATP approaches are very effective, and they can help you achieve some major corrections similar to what you can achieve with major osteotomies as well. PGK and PGF hardware failure, we have good evidence in the literature nowadays that their incidence is much lower when you're going with MIS techniques. So it's probably something that you should introduce into your practice because it can be very helpful over the coming few years. Thank you very much.
Thank you, Shyam.
Thank you. Thank you.
So yeah, Raymond, go ahead, please. Yeah.
Yeah, thank you, Dr. Sameh. That was an excellent talk, and I love lateral approaches to deal with deformity because I do find them far less invasive than the traditional open techniques, with significant reduction in blood loss, patient morbidity, and muscle disruption. The soft tissue and muscle envelope is far less disrupted. So thank you for your excellent summary. I'm just wondering, for the first case, do you think going back you maybe have corrected too much? Because I noticed that the C7 vertebra was actually posterior to the sacrum on the correction, the final correction. Do you think that for more elderly patients we should correct less? Because there is a lot of talk about that we shouldn't follow the strict the original SRS protocols. And there are formulas for accommodating for age as well.
Raymond, the simple answer is 100% yes. I overcorrected her, right? I corrected her to 20 years old when I shouldn't have done that, right?
Yeah.
So I should have accommodated for her age. But remember, that was way before the introduction of the formulas and the parameters to accommodate for age. Yet back then, that was like 8 years ago, but yet back then, we did know that you shouldn't correct every single patient to the parameters of, we didn't have the formula, but we didn't know, we shouldn't have corrected everything. You should have to respect physiology, that patients as they age, they tend to go into kyphosis.
Yes.
Nowadays, I would never do that, honestly. I would be more lenient and more easy with the corrections, and I wouldn't pull every single patient to the parameters of a 20 or a 30 years old.
Okay, yeah, thank you. And for the patients, are we all using anabolic bone agents? Because we all know that anabolic agents can reduce the incidence of PJF and PJK. So there are amazing drugs now in the form of romosozumab, and I think we are all probably getting DEXA scans for our patients when we're dealing with deformity, because one of the major problems is hardware failure or screw pull out, osteoporotic bone. So we have a lot more tools now at our disposal.
Absolutely. So for every single adult spine deformity, for every single fusion case nowadays, actually, I get a DEXA scan or a CTBMD preoperatively. If they are below the 3.5 mark, then they go on anabolics for 6 months before surgery. And then we take them to the OR, and we don't want to see them correcting to normal. We just want to see that trajectory going up in the right direction of corrections. And nowadays, also for every single adult spine deformity over the past 3 or 4 years, they get anabolics for at least 8 to 12 weeks post-op. That's an off-label use, obviously, despite the fact that we have a very good evidence in the literature of the use of anabolics post-op in adult spine deformity. So even if they are not osteoporotic, we give them anabolics for 6 to 12 weeks post-op if they're going for an adult spine deformity case. Now, when it comes to romosozumab, we started using it over the past couple of years. It's now available in the UAE. I prefer using it nowadays pre-operatively. Unfortunately, for post-operative use, I mean for non-osteoporotic patients as a post-operative use to aid with the decreasing the risk of screw pull-out and PGK, we don't have that much of an evidence as we have for Forteo as well. But I'm pretty sure over the coming few years, we're going to have some major evidence as well for the use of romosozumab in post-op and other spine deformity as well.
Okay, thank you.
Yeah, Sameh, I'm amazed at the amount of disc height you gained at multiple levels in these patients without a posterior facetectomy, without a posterior release. Would it cause any kind of a stretch neuropraxia on these patients?
No, I'm the majority of the neuropraxia that I used to experience earlier. Actually, particularly when I was doing obviously transpsoas from the retractor of the lumbar plexus and using the retractor for a very long time, I never had a neuropraxia from stretching the foramina too much or opening the disc space too much. I think what we are trying to put them at is the height that was intended initially to have before having all of that degenerative process. We're not pushing the envelope with or over distraction. And if you take a look at the facets of the majority of those patients post-operatively, you will not see any facet distraction because the majority of the time we're fish mouthing that disc space instead of offering too much of a distraction.
So
Do you
these disc space opened up on their own on positioning, or you have to manipulate?
No, so what I do nowadays is I started with doing that middle third discectomy, all right? Then I use one of those spoon curettes and start doing an anterior third and a posterior third discectomy as well. And that's because I'm coming from an oblique approach, so I can reach all the way down to the PLL posteriorly. I can even introduce nowadays a nerve hook into the spinal canal from an anterior approach, right? Now, once I do that, I put my sequential trials in, and at this point, I'm stretching the ALL because I have the trial into the disk space. So once I rip that ALL, I kind of lean with that trial over the end plate without pushing too much, and all of a sudden you'll feel that rip of the PLL as well. Now, once you took the PLL out, once the ALL is out as well, you have done the majority of the discectomy over there, then it's very easy at this point just to put your cage in to fill that space. So it's a matter of sequential distraction that you do, sequential distraction that you do by doing a proper discectomy, not just a middle third, but also anterior and posterior third, then taking the ALL out and eventually the PLL out by leaning on the upper vertebra using your trial or your dilator.
Do you do it one stage or do you stage your surgeries, especially the long ones?
No, I do them at one stage nowadays because the anterior approaches, obviously, we got faster and faster over the years doing those. So the anterior part doesn't take much of time anymore. And then it's a matter of putting some perk screws in the back. So the posterior part usually doesn't take much.
With the release of the ALL, do you worry about anterior cage migration?
Yeah. So initially, when I started doing those, I was doing some of those fancy cages that has some built-in screws as well.
Tabs, yeah.
Yeah, exactly. And then what I do nowadays, I use a screw and washer, but only at the apex of the curve. So I've seen in some of the x-rays that I shot that I'm using a screw and washer because this is the cage that I'm worried most about. And this is the cage that's likely gonna migrate when I flip the patient. But what I also do nowadays while I'm doing that anterior third of the discectomy, I kind of leave that small lip of the disc from attached to the lower end plate of the upper vertebra and a small lip of the disc attached to the upper end plate of the lower vertebra. So it's kind of hugging the cage in the front till I flip the patient. And once you lock the patient posteriorly, then the risk of migration is negligible. The problem is while flipping that patient, right? So I only worry about that at the cage at the apex, which the majority of the time is the L4-5 cage, obviously, and that's the one that I use a screw and washer, which is a very old technique that we used to use in the old days for an ALF cages, particularly when we used to use a femoral bone graft back then.
Excellent cases.
Thank you. Appreciate it.
Yeah, so I think with this, we come to the end. I've been wiser in the last 1 hour. Heard so many new things. It was very educational. The videos were spectacular. I think now the audience, the viewers know the probable, uh, uh, clear indications of each and every procedure and how these procedures can be done with minimal access uh, and minimizing complications and decreasing morbidity. Thank you, Middle East team, for a wonderful educative experience this evening. Thank you.
Yeah, thank you. Will any of you be going to the SMISS in Singapore? Because we'd love to catch up with you there as well.
We hope so.
Okay, if you can travel. If you can
Yeah,
welcome. Yeah.
Let's hope so.
Hopefully.
Yeah, the problem that we have,
we'll meet in person.
yeah, event like that could be in the same time, but if we let's say postponed it, it's depend on the current situation.
Yeah.
So I think that's we will attend. Yeah.
Yeah, I know flights are difficult out of the Middle East now. So
No, we can't do it.
Okay, okay.
But I think
We'll love to see you in
are,
person. Love to meet up and catch
most
up.
of you are attending Global Spine Congress, right?
Yeah.
We're going to be there.
And next week I will be in China also.
Okay.
Oh, okay.
Okay, guys. Bye. Thank you,
Yeah,
everyone.
take care.
Thank you.
Thank you. Thank you for
Good night.
organizing. Thank you.
And take care.
Thank you.
Bye-bye.
Take
Thank
care.
you. Bye.
Okay.
See you, Arvind.
Bye.
Bye.